Thank you all for joining United Spinal Association, the Greater Philadelphia Chapter's monthly educational webinar. Tonight, we are very excited to have Marnie Nuckowitz here with us for a talk about utilization of acceptance and commitment therapy strategies. Marnie received her doctorate of psychology degree in 2002 from the Philadelphia College of Osteopathic Medicine. She has been the neuropsychologist on the spinal cord injury unit at Jefferson Moss McGee Rehabilitation for 21 years. She provides individual, group, and family psychotherapy, as well as comprehensive cognitive assessments for individuals in inpatient care. Marnie facilitates peer mentor training and implementation for individuals who are experiencing challenges coping with new spinal cord injury or existing spinal cord injury dysfunction. She is also the founder of the Spinal Cord Injury Alumni Association, which facilitates the transition from inpatient care to community reentry and provides ongoing support, education, and peer interaction. During Marnie's webinar, if you have any questions, please use the chat feature and we'll hold the questions for the end for Marnie to review and answer. At the end of the webinar, if it is easier for you to have a verbal dialogue with Marnie, just raise your hand or let me know in the chat and I can unmute you so you can have more of a conversation with Marnie about any questions that you have. Also at the end, look at our chat box. We will have a link to become a member of United Spinal Greater Philadelphia Chapter if you are not a member already. We will also have a link to our YouTube channel that has this and all of our other monthly educational webinars recorded and available for you to watch at any time. So I would now like to welcome tonight's speaker, Marnie Nuckowitz.
Thank you, Meg. And hello, everyone, and thank you so much for joining. And it's really, truly an honor to be able to speak with you all tonight. And I've really had the privilege of working with individuals with spinal cord injury or dysfunction for the past 21 years, and have presented on a variety of topics, all of which were inspired by the brave and amazing people with whom I've worked. And I always say, I've said this for years and I'll say it again, that I've learned more from patients than any textbook or any class that I've ever had. And I really want to express my gratitude and dedicate this talk to the people that have inspired my ability over the years to really learn. So I always like to start off by talking about the psychological effects potentially of spinal cord injury. And again, not really knowing where everyone is in the process. Some of the stuff may or may not pertain to you. Some people may have completely skipped over these things, or some may be experiencing them right now. The purpose of it is not to have a negative focus, but also just to really, in case you are going through it, validate what you might be even silently going through. I want to point out different resources along the way, some of which are pretty easily accessed and others are a little bit more difficult to navigate, but I wanted to give you some tips as to how to do that. And just looking at ways not to just muddle through this injury, but to live your life in the most authentic and meaningful way. We hear that a lot, but what does that really mean? And I'll tell you this, and I'm going to say this throughout the talk. I hate toxic positivity. I really take offense to it when people say, don't worry, it's all going to be okay. The important message is that it's not a clear-cut issue, and as we know, that sometimes it doesn't feel okay. And there are ways to treat ourselves with patience and kindness as we learn to tolerate these moments, not to suppress them, but to tolerate them, while at the same time looking at our own personal values. And that's really what acceptance and commitment strategies are all about, to get our lives back on track. So I wanted to just highlight some of the protective factors. We spend a lot of time talking about what brings us down, but there are some really good factors that really help us to navigate our way through this. And so some of the things we'll be talking about that enhance our ability to cope with spinal cord injury. We know that it's really advantageous for people to live in the community, within the communities. Sometimes folks have to go to skilled nursing facilities, but once you're back home or in the community, that's actually more of a protective factor. Avoiding social withdrawal and trying to re-engage in your life. We know that these are obvious things and we want to learn ways to do that. Community reintegration and social participation, study after study and through clinical experience, we know have really been found to improve just overall quality of life and foster a sense of self-worth, confidence, competence in your ability to manage whatever goes along with the injury and your care, and an overall improvement in life satisfaction for individuals with spinal cord injury. And so these effects have been shown to have lasting positive impacts on both psychological and physical well-being. So we know that social support is helpful. We hear that all the time, but we want to take a closer look at what kind of support is helpful and how it's delivered, right? So obviously we know that holding up on our houses isn't the answer, but we also know that there are obvious barriers of community accessibility. So technology can really help us to feel less alone and to try to access some of those resources. And I'm specifically talking about behavioral health resources, but also just getting out to appointments and those types of things. And also throughout this talk, I want to say that your beloved family and friends, they mean well, they try, but as hard as they try, it's really difficult for them to be able to relate to what you're going through. And peer support is really a vital component to all this. Again, want to highlight that how people view adverse events really plays a big role in how you cope with it. So thinking this horrible event happened for a reason, maybe I'm not sure what it is yet, or at least I'm still alive. I have many more things to accomplish in my life, or my grandchildren still need me. These are just some examples of patients' statements to try to make meaning of this and to try to move forward, versus thinking like, well, they would have been better off if I had died in the accident, or I'm a burden now, or they would go on with their lives without me. So in trying to kind of modify that way of thinking proves to be a little bit more adaptive. Having a sense of productivity doesn't always mean paid employment, but study after study will show in clinical experience that a sense of productivity, whatever that looks like, whether you're back to work or you have a volunteer opportunity or you're a peer mentor, it really enhances self-esteem and fosters positive role models for other people, and really promotes optimism for both yourself and also the person that you're helping, and more adaptive coping. So just reviewing some of the sequelae of spinal cord injury, and I'm sorry, I know the slide and I took it from a study. It says psycho, that's just an abbreviation for psychological. But this really is just to illustrate that everything is overlapped with one another and everything is inextricably linked. You really can't talk about one aspect of a person or an individual without the other and how they kind of interface, right? So we know you've lived through this, the consequences of spinal cord injury entail much more than damage to the spinal cord. The lives of people with spinal cord injury, along with everyone around you, can experience profound, long-lasting changes in nearly every life domain. So there's some of the questions that you've asked: how am I going to go back to school if I can't even get out of the house, if I don't have a ramp? How can my mood improve if I'm always in pain? Again, one thing leads to the next. And I think a lot of folks don't really understand that. It's like, oh, I thought of that solution, but I can't because, my chair is not ready or whatever. So, when we look at earlier research, when spinal cord injury was being researched decades ago, and how folks with spinal cord injury were able to cope, and some of the theories just went back to like, well, it's a static experience, like one and done. Once you get through the initial phase of rehab and you learn how to live your life and adapt, you're okay. And undeniably, the majority of the psychosocial upheaval really happens most intensely, really after one acquires the injury, but challenges remain consistent through your life, and that. Spinal cord injury is a permanent condition that often requires lifelong daily adaptation. So you could go, maybe the first year is not that difficult, and then something changes. Your caregiver changes, something happens. So just to, kind of taking a look at how this is an evolving process. It's not always negative, but we want to be mindful of that. And with this, we're talking about traumatic spinal cord injury. And in many of my lectures, no matter what we're talking about in the topic, I often pose the question, it's really a rhetorical question, of which is psychologically worse. Having a condition from birth or childhood and getting kind of used to it, if that's such a thing, because that's all that you know, and that's how you've defined yourself, that's all that you know. Or having a sudden, often traumatic event that causes one to label oneself as, previously normal, in quotes, to something completely different. So again, there's no good answer, but the latter really poses a lot of psychological challenges. One thing that I find very interesting that studies show consistently, and you would think that the higher up the injury, the worse the injury, the worse people fare psychologically. But the one factor that consistently shows as having the biggest influence, besides having a great social support system and how people cope, is how you view your injury, how you view yourself, how you define yourself. And then the additional factor, and we'll talk more about this, if there's a component of self-blame. And we'll talk about maybe some folks got into high-risk situations where they felt like they shouldn't have, they blame themselves. Maybe someone was out on the road and you were just going to work. Well, I shouldn't have gone to work that day. People find ways to blame themselves when it was clearly out of their control. And that becomes a big factor as well. The, overarching theme is what just happened to me and taking me by surprise. And obviously no one is prepared for this. And it affects relationships. How could it not, right? So we know that relationships, a lot of them change after spinal cord injury, but not always in a negative way, right? And just thinking about the relationships that you have in your life, isn't it interesting? And I hear this from patients all the time that sometimes people come out of the woodwork, sometimes a coworker that you didn't really think you were that close to, all of a sudden they're coming to see you, they're checking in on you. And it's like, wow, I really must have had a big impact on them for them to, to feel so, dedicated to seeing how I'm doing. So that's always a wonderful surprise. And then sometimes there's a great disappointment regarding people on whom we thought we could count on for life. So it's often a mixed bag. I know a lot of people can relate to that. So the number of people that you have in your social support system, it may increase or decrease, but it's, again, the quality that counts, and the strength of and the feelings of support in our relationships, and the benefits that we have psychologically are found when individuals really feel that they have strong supportive relationships, and that really adds substantial meaning. I mean, this really isn't new information. I think that everyone pretty much knows this, but it may be just helping you to feel a little better about it. It's not in the number, but it's obviously in the quality. And that can really significantly lessen feelings of grief and loss relating to the injury. And we'll get it also into the types of support and people that can really relate to what you're going through. So study after study has shown that it can have a very positive effect on you, both psychologically, but also physically, because then if, your friend is going out and doing things and understanding what you're going through, then you're more likely to adhere to treatment and be engaged in things. So, when you receive care from someone, whether it's your parent, or a child or a spouse, and we know that some of you are going through this, and there are many challenges to navigate, not just initially with setting the boundaries and defining the roles, but also on an ongoing basis. So what I like to call the guilt versus gratitude seesaw, and I hear this all the time, and patients will say to me, I'm so grateful, I'm so incredibly grateful that my daughter quit her job just to take care of me. And sometimes they're paid caregivers, but it's a change in them, in what they've been doing. But I also feel really guilty for ruining her life. And again, that mindset of ruining, and that's something that we want to look at and how we look at it. So on the flip side of things, I also run a caregiver support group. I can tell you about that resource at the end too, but I run it twice a month. So I talk to caregivers all the time. And when I say caregivers, I don't necessarily mean people who are providing you with hands-on care, but anyone that's connected to someone with a spinal cord injury that is providing love, support, that's affected emotionally by it. And I hear the stressors, but I also very much hear people say things like, you know what, this is invaluable. This is so invaluable, and it's changed my relationship, and it's really made me closer to that person. And I'm very grateful for that opportunity. So also, what's really important is not viewing your relationship as being imbalanced. And this is what I mean by that. So if your husband, let's say, is your care provider, and so I hear people say, I'm so lucky, he's sacrificing so much. What would I do without him? I'm so lucky. And I always challenge people to say, hey, he's lucky to have you too, in a very equal way. You are still very much a viable part of that relationship, and that needs to be balanced. Another challenge that I hear from folks a lot is this overprotection. I don't know if anyone can relate to that. When the caregivers do too much, we often see that initially, in rehab, where the person is very afraid to let the individual with spinal cord injury navigate their way back home because they're afraid of getting hurt or they just want to do too much. So, the caregiver's protective behaviors really can facilitate a dependency that you don't want, because you want that autonomy. You want that sense of self-efficacy that you can do it yourself. So again, it goes back to communicating and saying, I'll ask for help if I need it, but here's the flip side of it, and I'll accept it if you offer it to me, right? Because I know that there are challenges with that too. So, and a lot of these things are talks in and of themselves. We could go on about some of these things. This is a lecture in and of itself, right? But regarding intimacy, the role transition from partner to caregiver and trying to maintain both has also been found to cause stress, sex and intimacy among partners and romantic relationships. And each couple is different. Each family is different as to how to navigate that. Perhaps the key is to bring out these issues. Excuse me one moment. I see the chat and I'm just making sure that everyone can still hear me okay. Sorry, okay. Okay, I'm definitely gonna get to that. I just want to make sure everyone can still hear me, so I'm gonna just shrink that. Okay. So again, in the initial phases of rehab, and that's where I'm coming from, but I also, as Meg said, I've started the SAI Alumni Association, and this is a great way to kind of bridge that gap from inpatient to outpatient. And I'll talk about how we've changed terminology. You don't just discharge. You don't get discharged from treatment. You graduate. This is your postgraduate work, right? So in inpatient rehab, we offer coaching and trying to negotiate those boundaries, but it's never too late. You could have received care maybe like 15 years later. It's never too late to say, hey, you know what, I'm not comfortable with how this looks. And we have lifetime follow-up here in the clinic. That's one forum in which to talk about this, having family therapy, that kind of thing, bringing it up in the Alumni Association. There's always a way. So the overarching message again is, it's never too late to have open communication about things in your life, that you want to change. So, sorry. I am so sorry. I'm trying to scroll down. Yes, here we go. Okay. Now, we've all heard these things being said by well-meaning people. And again, just, talking about folks who are still in inpatient, or even those who are, who've been out of inpatient care for a long time. Are you walking yet? Or why do you have to be so negative? The only thing standing in your way is your attitude, because that's helpful, right? And I can relate to what you're saying. I was in a cast for 6 months. No, you can't. You can't. I know that, and everyone has an opinion, and we can say a lot of things about like what opinions are, right? And we don't welcome them all the time, but most people are well-meaning, and people try to relate, but they can't. And what happens often is that you end up feeling invalidated, and then you get angry, and people just fundamentally don't really understand. Again, no fault of their own, and it just can leave a person feeling more alone. Maybe a lot of folks, the spinal cord injury is really poorly understood. Initial phases of rehab, it's easy to get that education because you're here, but again, that can still be accomplished in so many ways. United Spinal Association, there's so many conferences, staying connected to the clinic. There are so many ways to get that education. And so again, toxic positivity leads person to feeling just more alone and not understood. And that can feed into the concept of ableism, which I'm going to talk about in just a second. And that's not a good thing. We don't want that. So ableism is if folks who aren't familiar with that, is a disability-based discrimination that results from looking at able-bodied people as normal and superior to people with disabilities. Now, that's scary enough when we think or we perceive that others are looking at us that way, right? But people with spinal cord injury often view themselves that way. And so regarding social connections, the higher this self-stigma is what it's called, higher self-stigma was found to influence a person's social choices. So whether you disassociate from old friends or connect with a new set of peers, stigma has consistently been associated with a sense of social disconnection. So it's something that we try to target early on. And again, the SEI Alumni Association is really a great way. And I'm not trying to plug that because I don't get any money for that or anything. I'm just saying that I feel like it's a good way for folks to connect. I've heard people say that, you know what, it keeps me positive. It keeps me in touch with folks, building new connections and that kind of thing. That gets lost after you leave not just inpatient care, but then maybe have home care, then you go to outpatient, and then you're done. And then what? So this is really a good way and a lot of folks still prefer in-person connections. When COVID hit, I tried very, very hard, and I still do, to put up virtual links and have people connected that way. But a lot of, to be honest, we miss a lot when we're not looking at the person and we're connecting with them in person. So just something to keep in mind. It really does foster a sense of community. So some of the psychological fallout, just to mention again, not trying to take a negative spin on this at all. For some people, you may not even have experienced this. Some people may be experiencing this now. But again, wanting to say that people with SCI often require continual adaptation and adjustment, and psychological challenges can be significantly more prevalent for folks with spinal cord injury when we compare folks to the general population. So again, neither level or injury nor severity of functional impairment has been associated with the amount of psychological distress that people experience. You would think so, but it's actually kind of counterintuitive. But it suggests that other factors contribute more to psychological distress than the more obvious physical ramifications. So, and the literature's really mixed. So a lot of studies show that this, the depression, anxiety that kind of wanes over time, but that passing time alone doesn't resolve depression if it's not recognized, if it's not treated, if we don't talk about it. So, and it's often overlooked in rehab and post-injury adjustment because, you're trying to get used to the spinal cord injury. You're trying to get a bed delivered at home. You're trying to wait shift. You're trying to get used to all of those things. So this sometimes takes a back seat. And then all of a sudden you're left with the realization that your life has changed. So in general, folks who have had some behavioral health challenges prior to the spinal cord injury sometimes are often at greater risk for developing depression, anxiety, that kind of thing. So I always ask individuals that I see, have you ever been treated for depression? Have you ever been treated for anxiety, other types of things? And so folks aren't lying or bending the truth, but sometimes they'll say, oh, no, I never had that. And then I'll take a look at their medications and it'll clearly say that they're on psychiatric medications. But sometimes we don't recognize that label. Sometimes labels aren't helpful, or the primary care physician may have put you on something to help sleep, to help pain. We know that Cymbalta helps pain, neuropathic pain, and mood at the same time. Sometimes people are more willing to take that and don't really label themselves as depressed. But it's really important to say, hey, you know what, I guess so. I do have that history. So just taking a look at depression after spinal cord injury. So studies tell us that over a third of individuals will experience some type of depression, anxiety, or a combination of these symptoms. And it's really hard to pull that apart, right? Because, when you're depressed, you're often really anxious. And a third of people remain depressed about 1 or 2 years after the onset of spinal cord injury. And I mean, the advantage of being an inpatient psychologist, that's really the prime time to identify those symptoms and say, hey, I can get you some help when you leave here and encourage treatment. But sometimes people are really not in need of that. And again, have that adjustment reaction a little bit later. But I wanted to say again and again and again, I'm sorry if I'm repetitive, it is never too late to identify those symptoms, seek assistance, and lead a better quality of life. But once again, saying that pressure injuries, bladder issues, lack of community mobility, a lot of things get in the way of seeking therapy. But virtual therapy is an option. And later on, I'm going to talk about ways to access some of the resources that are a little bit more difficult. But the other thing that to really kind of get past, and still the year 2024, soon to be 2025, I personally think as a psychologist, there is still a lot of stigma associated with behavioral health treatment. How many, it's less, but how many times I go into a room and they know that they have a session with a psychologist, and they say, I'm not crazy, or, I know you're not. We have psychological services for every person who comes in here because this is hard. This is a significant life change, and support has been beneficial, and we know that. So study after study after study has documented that untreated depression leads to worse physical outcome. And that makes sense, right? Because when you're not feeling like yourself and you're depressed, you don't really feel like doing the pressure reliefs. All of a sudden they become, fewer and farther between. Maybe caffeine gets missed, and maybe that leads to a bladder infection, and then you get more depressed, and that's the vicious cycle just kind of continues. So we really want to try to break that cycle, recognize it, talk about it, all that. So, most of us kind of know, and it's fairly obvious, some of the symptoms and the signs of depression, and it could be in your awareness. But sometimes people show those symptoms physically. And what I mean by that is that, you don't feel well. There's a general sense of malaise or pain expression. And by no way, shape, or form am I saying that you don't feel pain. You definitely, can feel a lot of pain, but sometimes it's expressed in those terms physically. And then pain and mood become, again, inextricably linked, and it's hard to pull them apart. Agitation, irritability, just having a difficult time snapping out of it, and just a general sense of hopelessness can kind of take a life of its own. And it's, again, really hard to maybe try to figure out, what is the entry point? How can I make a change, right? And others may notice. And the most important thing, I think, the takeaway message is to try to be open to that feedback and not look at it as criticism. Because again, most of the time people are telling you this because they love you, they care about you, and it's constructive, right? So, as we mentioned, having previous behavioral health struggles may predispose individuals to coping challenges, especially if you don't already have a provider in place. But I can't say enough times that we take psychological treatment very, very, very seriously here, and we value behavioral health treatment just as much as any other therapy. When folks come in and they have a pre-existing therapist and they want to continue to see them, I'll still see them, but I will block the time off. I will say to the PTs and OTs and the speech therapists and the doctors and radiology, you can't see this patient between 10 and 11 because their therapist is coming online and offering them support. So that is the priority. Another common thing, and again, a lecture in and of itself, is using substances, medicating oneself, using pain meds. Oftentimes we have legitimate pain, but not over relying on it if you don't actually have as much pain, and trying to avoid or and saying, everything hurts and I just feel like just, escaping, right? Also, just again, going back to how we view the injury, and not to pathologize this, but it is very common for folks to say, I've been a good person my whole life. Why did this have to happen to me? I've tried to do the right thing. I've done a good job, at work. I've taken care of my mom, that kind of thing. So again, pretty common, don't want to pathologize that, but staying stuck on only that is a risk factor for depression. A normal way of thinking, but how you answer that question makes a difference. And self-blame, like I said before, I shouldn't have been out that night, I wouldn't have gotten shot, or I wasn't a good enough son. Let's face it, be honest with ourselves. People find ways to blame themselves even when something was completely out of their control. And we don't want to do that, where we become our own worst critics. Feeling lost, and so I don't know how much this looks like it's highlighted with the font there, but I wanted to say that feeling lost and not being able to define yourself in a way that's outside of your previous physical abilities is a risk factor for depression. The ability to transcend this is a challenge, and that's really what we're talking about. So briefly speaking about anxiety, about 30 to 45% of people with spinal cord injury will experience sometimes significant levels of anxiety. And it really seems to heighten during the initial period of injury, but often declines around the 1 year post-injury mark. If you're someone who's predisposed to being anxious, then sometimes it won't level off and it needs to be addressed. And like I said, depression and anxiety are often linked. And we thought the future was going to go one way, and now things have radically changed. So some of the things going through your mind: finances, how will I take care of my family? And we know that anxiety can really impact on sleep and it can keep us stuck. So has anyone ever said to you, well, you're just overthinking things, try not to overthink things. That's really helpful, right? You can't just turn that off, especially if you're someone who, considers things at all angles and it impacts your sleep and you're an overthinker. The flip side of that is that you're smart and that you've probably preempted a lot of things from happening. But sometimes we just can't shut our brains off, right? A lot of people can relate to that. Just briefly, talking about substance use disorders, and I'm not talking about just like smoking weed, here and there, or whatever. Sometimes people use tobacco, but this is something that folks with SCI sometimes can be at risk for. They're common in the general population and even more prevalent with folks that have spinal cord injury. Just for some perspective, 1 in 5 Americans has had at one time or currently a behavioral health diagnosis, and 1 in 12 has a substance use disorder. So using these avoidant passive coping mechanisms can really be detrimental. So again, going into something that folks may or not be experiencing, PTSD or post-traumatic stress disorder really can only be diagnosed 30 days and above and beyond after you've experienced a life threatening trauma of some sort or witnessing it, because actually the nomenclature on behavioral health presentations now extends the definition that you witnessed it, that you were a party to that, right? And so PTSD is something that most people, the good news is that most people don't develop it, but for those who do, and sometimes it's out of people's awareness and they think they're going crazy. And it's for that reason that I like to include it in talks. Sometimes people say, oh, I've heard about that. I'm fine with that. I used to have thoughts that popped in my mind, but now I'm past that. But it can be very debilitating and often chronic, and it's associated with what we call intrusive ideation or intrusive memories. And these are things that pop in your mind. You don't want them to. You're trying not to think about things. The more you try not to think about it, the more they pop in, right? Sleep disturbances of any sort, sometimes sleeping too much, sometimes having difficulty initiating sleep, or what we call middle of the night awakening, or awakenings, right? And avoiding anything that reminds you of the trauma, whether it's on TV or like, I don't want to talk about that, right? Negative cognitions and mood, and increased arousal. What I mean by that is like a hyper arousal or an exaggerated startle response, and a lot of distress emotionally and impairment in functioning. So, we live in Philadelphia. Trauma exposure is unfortunately very common, right? And so if we just look at the world, it's estimated that 70% of the world population has been exposed to some type of trauma at one time or another. And I haven't looked at the statistics in the last month, but I would dare say that people in Philadelphia, it may be close to 100%. Some people tell me they go to sleep at night and they can hear gunshots. Good news. Most people will only transiently experience symptoms, but again, individuals still symptomatic 4 weeks after the trauma may have a lasting presentation. So it's good just again, sometimes when I just educate people on what PTSD is, sometimes that's all that they need, right? And then they focus on the rehabilitation and this kind of takes a back seat. But I wanted to at least provide you with this. So most people who survive traumatic experiences are affected emotionally, of course, but don't require formal mental health interventions. And after about 3 weeks afterwards, the slope of recovery tends to flatten, but the PTSD rate is interestingly 20%, up to 20% following assaultive violence. And so the data really suggests that the magnitude of the traumatic load gets higher. As it gets higher, then the rate of PTSD gets higher. And so a lot of folks who come in to rehab or that I see and present on an outpatient basis, sometimes they start talking about earlier trauma. And you may think, well, that has nothing to do with what I'm going through, but that's actually not true, because when you're going through a traumatic event like this, earlier trauma tends to resurface, things that you maybe haven't thought about in years. So that's just good to know, right? Donald Meichenbaum is someone that I had the great advantage of seeing in person years ago when I was in the doctoral program, and he's one of the leading researchers. I don't think he's doing any talks anymore because he's old and I'm old, and but he was a guru. And I had the good fortune of seeing him and Edna Foa, who were really the leaders of the field in PTSD and OCD. And he came up with like an algorithm and summarizes the research on what individuals need to do and not do to avoid development of persistent PTSD. If only it's as simple as this, but this is kind of an outline, right? So when you make trauma essential to who you are as a person, and it becomes who you are, right? That is also a risk factor. And exhibiting what he calls the hindsight bias, which is this inflated sense of responsibility. So when we go through the trauma, we're not to blame, but somehow afterwards we rewrite that script and we do it so that's like, well, I should have done this or that, right? So we'll go into that a little bit later on moral injury, any kind of guilt or shame heightens your risk for that. So how we tell our stories about what happened to us and write or rewrite our narratives is vitally important to how we view ourselves as living our best lives with spinal cord injury and the world and our ability to move past traumatic events. And that's not by suppressing the traumatic events, it's by moving along with it. So traumatic events can change how individuals perceive themselves in the world, and these assumptions that the world is a safe place sometimes can be shattered, so we need to rebuild that. So, again, briefly with PTSD, shame, guilt, and the self-blame game. People who feel shame, strong shame, often really struggle with talking about that in therapy and revisiting the traumatic experiences and describing them out loud in front of the therapist. And, we see this for a variety of traumas, sexual assault, childhood sexual abuse, where the survivor sees themselves as wrong, bad, dirty, or that kind of, or that something that he did or failed to do. And so, I found this to really be a hot spot or a sticking point in my treatment of PTSD. And what I try to do is emphasize that keeping it a secret will really reinforce these feelings of guilt, shame, and self-blame. People get stuck. What's the biggest reason that people don't disclose things in therapy? Is saying it out loud makes it true. Also just kind of the fear what you do with that information, and everything's always private, of course, but the fear of being judged or looked upon in a negative light, or that you're going to do that to yourself, right? So therapists, whoever you've had or will have, or if you're considering, should really convey a compassionate and non-judgmental response rather than blaming and this repulsed response that sometimes people think that, or anticipate, right? And really kind of just highlight that what you're doing really reflects bravery and forthrightness for taking control, right? And reminding people that much of what we tell ourselves after the trauma occurred, and again, we inflate our sense of responsibility rather than the particular thoughts that went through our minds at the time that the event was happening. So again, briefly, everything is a talk in and of itself, and I'm available for questions anytime after this, right? But I just wanted to say that prolonged exposure therapy really holds the gold standard in having, and going through a traumatic event. And, there's a limited efficacy of medication. The medication isn't the end all be all. And PTSD guidelines have really designated this as the first line treatment. So bottom line is that it really emphasizes the central role of successfully processing the traumatic memory and helping to ameliorate the PTSD symptoms, and addresses the fear that people are going crazy. So what it does is it helps them to relive the experiences in their minds and kind of rewrite what happened and figuring out where the sticking points are. And the take-home message for anyone that's considering this is try to expect that you'll feel a little worse before you get better, but avoiding the trauma-related memories and images and all that only reinforces the symptoms. And that's all I really want to say about that, because again, we could go on about that, but just wanted to give you a little bit of education about that. Behavioral health resources is something that I try to help everyone kind of tap into. And I'm going to be honest and say it's been bad, especially since COVID. And some people say, well, why are you making the appointments for these people? They can do it on their own. You know what? If you're depressed and you're already trying to navigate your way through spinal cord injury, and you're calling places where the webpage clearly said that, oh, you take my insurance, but it's like, well, no, we haven't taken that since 1998. That's really frustrating. And so if you're really feeling depressed, and you're running into brick walls and no one's calling you back, it's extremely, extremely distressing. So I am always available, and I want you to know this. There's no prior affiliation necessary with any kind of Jefferson situation, whether inpatient, outpatient. I don't have to know you, you don't have to know me, anyone. I will help anyone access behavioral health resources. Long wait times, I have kind of a way of just kind of navigating through that. So here's my contact information. I know you already have it, and I'll give it to you at the end too. Also, just so you know, insurance companies usually have care managers that can help you to navigate your way through it. So I just wanted to mention that. Medication versus psychotherapy. I am a psychologist in the state of Pennsylvania. We do not prescribe medications. Sometimes some certain states allow psychologists to do that. Pennsylvania is not one of them, but in the ethics code, we are ethically obligated to explore medication options with folks who we feel are struggling, saying you may benefit from a pharmacologic intervention. So a lot of people say, well, I don't want it to have I'm already on so many medications now. I'm 20 years old and now I'm taking blood pressure medication. I hear you and I respect that. But, and sometimes people don't need to have that. And sometimes they need to kind of just move through it without medication that is necessarily for mood. Sometimes medication is helpful for sleep. Sometimes just targeting the sleep disturbance or appetite, that kind of thing. But trauma changes brain chemistry. And sometimes it makes it a little bit more palatable to have the aid of medication in the short run and not for the rest of your life or whatever it is that people may think they need to be on. So just something to keep in mind. And it's oftentimes that a combination of medication and psychotherapy can be the most efficacious. So just talking in general about positive psychological well-being. Once again, I want to say this is not the tyranny of positive thinking. What is it? So it's just, although individuals with SCI clearly experience emotional distress, and we've talked a lot about that, significant positive experiences such as strengthening connections with loved ones can also emerge. So when we include positive psychological health in our treatment, which again traditionally focuses on deficits, what can't we do, and distress, we empower individuals not to survive, but to thrive. Here's what we have always been able to do. Here's what we suddenly can do. So despite the challenges of managing SCI, most people, want to maintain an optimistic spirit, satisfaction with their life, and gratitude, right? So just kind of practicing this has again been linked to reducing secondary health complications and greater quality of life. So a lot of individuals feel pressure to think positively, and that if you don't, that it's a character flaw. And again, that can lead to poor clinical outcomes and disease setbacks because it's not just attitude, and it's if you don't have a poor attitude. So just in general, resilient individuals, do you define yourself as a resilient individuals, or a resilient individual? That's something that can be instilled at any stage of the game. So one thing to keep in mind is that resilience and post-traumatic distress can coexist. Decades ago, I remember I ran a therapy group for older adults who were very, very depressed. And they were living in an assisted living facility. And I remember someone said, I don't understand this. I know I'm depressed, but I also feel like a sense of excitement about the future too, with new opportunities. And I know the recreational therapist was helping me to run the group. And she piped up and said, you're allowed to have more than one feeling. And I thought, well, that's kind of condescending, but I thought, what, sometimes it's not so obvious for people to come to that conclusion. And having that sense of resilience while still struggling with trauma can very much coexist, right? So people can exhibit resilience in one domain and also at various times in your life, but these are fluid processes. So creating an alternative narrative and rebuilding your lives with a major focus on individuality and also just focusing on values. So one important component to include is, what did you do to cope and survive and not take a victim stance? Focusing on the unfinished business that you clearly have in life and the desire to help others and still be there in their lives. And benefit finding is also very important. we surely wish this never happened, right? But to use the term silver lining sometimes is can evoke kind of anger. It's like, well, what positive can come out of this? But benefit finding is also very important, and having the passion to pursue long-term goals. And so that's when we really talk about this concept, that was developed by these psychologists, Tedeschi and Calhoun, and they first defined this as, noting that in addition to experiencing the negative effects of trauma, people exposed to even the most traumatic events in life may perceive at least some good emerging from their struggle, right? So psychopathology is not inevitable following spinal cord injury, and most people demonstrate resilience and procure good outcomes despite these challenges. And in fact, stress-related growth, benefit finding can occur for many people. And also for caregivers. So again, in my caregiver support group, I hear a lot about that for some of the caregivers. So, and how can that be accomplished? Volunteering, the peer mentor program, giving one a sense of purpose, importance, and leadership. So maybe you received peer mentor support while you were inpatient, or maybe shortly afterwards, but now you're in that role. You have the ability to change someone's life. And what I have found time and time again is that people grossly underestimate the positive impact that you have on other people, simply when people are watching you and they think, wow, if she can do it, I definitely can. And I think that people just really underestimate that. A quick guide to achieving this, as we will mention with acceptance and commitment therapy, we first need to acknowledge the struggle, the disruption, the need for something in your life to give. And then we need to rewrite the narrative and focus on actions. Now, part of that, because we wanted to talk about acceptance and commitment therapy, part of that is mindfulness. So what is that really? I've heard that for decades, and there's no one operational definition for that, but it's practiced in various religions and secular traditions, and it plays a very important role in positive psychology, and it can be practiced in many different ways and lots of different forms, right? So what it generally does is that encourages people to observe our thoughts without criticizing them, and helps us to appreciate the present moment by reducing stress, by accepting experiences as they unfold, right? Breaking free from our habitual thought patterns, right? So when we judge ourselves like, oh, why do I have to think that way? That just makes it worse. And who's our biggest critic in life? Oftentimes it's us, right? So mindfulness really trains ourselves to just being kind and patient with ourselves. And it really gives our mind a break from deciding how we should or feel or react every moment, right? So as we're going to see with this type of thinking, cognitive behavior therapy, which is something that I've practiced over the years, really actively challenged these types of beliefs that we see here. So when we see acceptance and commitment therapy strategies, or we say FACT, because it's focused sometimes when it's adapted to like an inpatient setting, or when it's just like abbreviated, it gently accepts what comes into our minds and then looks for alternate ways of looking at ourselves. So if I said to you, don't picture a pink elephant in the room, don't do it. Well, now it's impossible not to do that. So when someone says, well, just don't think about that, or just don't focus on that, is that really helpful? I know, again, people are well-meaning, but it's really difficult. So what this essentially does is it allows you to have those thoughts. You're still going to have those thoughts, and you're not going to criticize yourself for having those thoughts, but you're going to add to them, and you're look at alternative ways of looking at it, right? So looking at focused acceptance and commitment therapy, and I know we're running out of time, so I just will be brief, that if posit said if time is limited, and it often is with folks, therapy really needs to be patient driven. So you're in the driver's seat here, and that the psychologist's mission is to help the patient achieve meaningful behavior. So I do this a lot while folks are in the initial stages. So it's really predicated upon the belief that most people, most of you, this is the good news, are equipped with the psychological tools to transcend their suffering. So painful experiences, again, can't be controlled or eliminated. So it teaches people to really make room in their minds for the distressing feelings while building acceptance for yourself and compassion for others. And really the focus is on personal values and psychological flexibility. And it really aligns with a collaborative approach that the psychologist and the patient are in a horizontal stance. I'm not telling you what to do, how to feel, how to be, right? And we really the saying in this type of therapy is we are in this stew together, right? And the people that with whom you've worked over the years and rehab professionals, it should be a kind of a collegial, collaborative thing, right? It's almost as close to a friendship as you can possibly get in a professional way. We're in this together, right? And I think that change can really only be achieved in that manner if you feel that sense of alliance with the people with whom you're working. So just showing up and observing, noticing things that you didn't before is a win, right? We get so caught up in our thoughts. Being proud of anything that we do, no matter how small, is really, really important. And we're so afraid of being criticized by others. Again, who is the loudest and harshest critic we know? And why do we bully ourselves? So I hear people say all the time, I'm not making any progress. And is that really true? And just really being in the moment and reviewing all the things that you're doing right now, reviewing the things that you're doing is progress, right? Everything is equally important. And again, I'm giving you the tenets of focus, acceptance, and commitment therapy, and acknowledging the wins. And even small or large, everything is equally important. And always asking yourself this question: what can I do in this very moment? And that interrupts going down that rabbit hole of feeling like you haven't accomplished anything, and acknowledging those competing thoughts without judgment. Every moment in life is an opportunity, right? And maybe establishing a system, perhaps monthly, to kind of, go over your goals. Am I on track for my goals? Goals and expectations aren't the same thing. Expectations are things that we impose on ourselves and often come with a price, like, oh, well, I didn't do that this year. But goals are something that always need to be revised and that we're working on, right? Staying true to your values. And that's really what it's about, and putting things in action. And I really just want to take a moment just to say that looking at labels is vitally important. When things suddenly change, we may have a very difficult time adapting, and we need to make sense of who we are and look at, like, well, I was a runner, I can't do that now. I was an athlete, I was the one who made all the money, and I shot hoops better than all of my friends. And I often give the example of, like, well, if I suddenly couldn't be a psychologist anymore, that was taken from me, and I strongly identify with that. I ask myself, why did I become a psychologist? Well, I love talking to people. I can still impart that sense of connection with people, even if I'm not actually in that role, right? I'm still that person. So briefly talking about the SCI Alumni Association, getting involved in different causes. One individual is a strong advocate for the cessation of gun violence. One of the topics that we've been talking collectively about recently is holding the airlines accountable for your wheelchairs and not getting them lost or injured, or just all different types of things when it comes to travel. One individual, unfortunately, was shamed and stigmatized when he took his family to a water park, and just holding places accountable for folks with spinal cord injury, and making things more accessible. So shifting the focus from yourself to others is also, pretty meaningful. And that's really what we do. So sorry to have rushed through the last part of it, but I want to go through the chat section now. Let's see.